everybody, and welcome to another interesting episode of the SmartEducation Podcast. Happy to have you here with us, all those listeners. And first of all, a welcome to Dr. Alison Grimaldi.
Thank you very much for having me here and in your beautiful country.
Thank you. We were so happy to have you on our podcast today, and thank you for accepting this invitation. As I said earlier, I would want to give you only just 1 minute to introduce yourself. For the few physios who've never heard of about Dr. Alison Grimaldi before, how would you describe who you are and what you do, Alison?
Well, I'm a private practitioner in Brisbane, so I have a clinical practice in Brisbane. So that's my main focus as a clinician, but I also have a special interest in research. So I'm a senior Adjunct Research Fellow at the University of Queensland, where I continue research. And I'm also an educator. So I teach onto the Masters programs at UQ and then teach around the world, conferences and courses.
Mm-hmm. So actually, in 3 words, you're a physiotherapist, a researcher, and an excellent educator. Yeah.
Well, I hope so.
Yeah, it's true. And now you're doing a European tour. And how are you enjoying your stay in Belgium?
Yeah, fantastic. Love Belgium. It's such a beautiful country, beautiful cities, and it's good to see some rain. We sometimes forget what rain looks like in Queensland.
Yeah. Well, we have the honor not having you for 1 day, but actually for 2 days in Ghent and in Leuven. You saw a little bit of the country already. And you were having a course on lateral hip and buttock pain. And that's why we wanted to invite you to do this podcast. What's important during the whole of your course is you explain a lot about the LEAP trial, which is a multi-center randomized trial, that has been published exactly 1 year ago, so it's still fresh, about the management of gluteal tendinopathy. We can go on and discuss this for a long time, but maybe it's better if people want to know all about the design of the study and the methodology, we should refer them to your website or to the BMJ website, because it's freely accessible, it's open access. But let's skip maybe that part and go straight to the results. What can you tell us about the results of that study, and maybe a little bit introducing the study itself?
Okay, so the LEAP trial, we had 204 participants. So they were males and females, but more females than males. So around the 50-ish age, which is fairly typical for this population. So they were divided into 3 groups, and we had one group that did education and exercise, one group that had a single cortisone, and another group that was a control group that got some very basic information in a pamphlet. So they were followed over 12 months. So we had 2 main outcome points at 8 weeks and at 12 months, and we compared outcomes at those points. The 2 primary outcomes were a global rating of change score and a pain score on a pain numeric rating scale. So the global rating of change scores is a 11-point numeric scale, but an 11-point scale from very much better to very much worse. Mm-hmm. So the outcomes were dichotomized into success or no success. So success was moderately better, much better, or very much better. Anything less than moderately better was considered not to be successful. Mm-hmm. So at 8 weeks then, we found that on the GROC scale, the global rating of change, the education and exercise group was superior to both to the cortisone group and to the wait and see group. So we had about an 80% success rate with the education and exercise. The cortisone group had around just under 60% success rate, and the wait and see group at that 8-week point had about a 30% success rate. At the 12-month time point, the physiotherapy group, the education exercise group, had maintained around that 80% success rate and was still superior to both the cortisone group and the wait and see group. But at that time point at 12 months, there was no significant difference anymore between the wait and see group and the cortisone group. So there was not a significant difference there, but the physiotherapy group, education exercise, was still substantially better. With the second outcome, which was the pain outcome, at the 8-week point, which we didn't actually expect. At the 8-week point, the physiotherapy group, so education exercise, was again superior to both cortisone and the wait and see group, the control group. We had expected that perhaps the cortisone would be better than the education exercise early on because it has such a rapid effect. But in fact, the physiotherapy group again was more successful, so superior to both the other groups. By 12 months, the education and exercise group and the cortisone group were both better than the wait and see group, but there wasn't a significant difference anymore at the 12-month point in the pain score. Mm-hmm. But the global rating of change and quality of life scores, it seems to reflect more quality of life, was still significantly better. So the 80% compared to the 50 to 60%.
So that shows us that education on load management in combination with an exercise program was superior to the corticoid injection group and the wait-and-see policy. Mm-hmm. Yeah. Well, we see that already in our practices as well, but what I tend to see with participants during the course, or maybe also in my own practice, is that sometimes we do generalize the condition a little bit. I mean that we tend to use the same treatment protocol a little bit, some glute work, some myofascial treatment techniques, and some stretching. And during the course, I found that you gave us, or you provided us also the insight that it's important to get your basics right if you start with an education and exercise program. And I mean the basics more of exercise treatment and doing some proper motor control work because a lot of us maybe jump straight away to the fancy and more progressive loading exercises. And is that also an important message that we can give to physiotherapists listening to this podcast?
Yeah, absolutely. And I think that's a really important foundation. And Kim Allison's work, so Kim Allison was a PhD student on the LEAP trial. So she showed that people with gluteal tendinopathy have motor control issues, so have variations in their kinematics during movement and have variations in the way they recruit muscles. So I do believe that's a really important foundation to lay for our rehabilitation. If we do jump straight into strength work, but they're not moving well or recruiting their muscles well, sometimes that may just reinforce some faulty strategies. Mm-hmm. So we do want to head towards strength, but we want to get a good foundation first of good recruitment of muscles, learning how to control themselves well, and particularly in that frontal plane, controlling where the pelvis and the femur is, controlling where the trunk is. And then on that good foundation, we can build into heavier load strength work.
Mm-hmm. I agree. Thank you for sharing that. When it comes to your clinical work and you put into practice to what you've been doing in research already, what are the things that you see that your patients are struggling with? Why is it sometimes that not everybody responds in the same way to what we expect them to do?
Yeah, and that's a great question because everyone doesn't respond at the same rate in the same way. Mm-hmm. So we provide a program that is individualised in that everyone progresses at their own rate. So our criteria for progressions are things like you have to have good motor control, no significant aggravation of your pain, and working at a hard enough level. So once the exercise becomes too easy, then we progress. But that'll be different for different people, so there will be different rates of progression. But also for each individual, there might be different things that might be contributing to their pain or irritating that tendon. So in my clinical practice, they provided a guidebook, and that guidebook has all their exercises, their load management. And in the back, we have a flare-up guide and we have a troubleshooting guide. So the flare-up guide is about what does the patient do when they have a flare-up, because sometimes patients fail to progress because if they get a flare-up, they stop doing anything, and then it slows down their progress again. So we tell them if you have a flare-up, try to have a look at the things, go back through the load management, try to figure out what things might have flared up your pain, address those issues, but don't stop exercising. But if you are doing a higher level exercise, just regress to the one before. Mm-hmm. So even if they do a double leg squat and a double leg bridge and they're isometrics, they're your base program. So if you get those going again, then you gradually just progress through back to where you were. Mm-hmm. So those are good tips for patients. They can use some heat on their hips. Sometimes that helps heat around their muscles. Mm. But particularly going back to the basics and looking at their load management, the instructions they've been given, regress a little bit in their exercise and then progress again. And, of course, come in and see the physio for review. Mm-hmm. And then for troubleshooting guidelines, and this is something that the physio will usually use with the physio. So the physio sits down and goes through this with the patient. So if the patient's not progressing at the rate they would hope or that we would hope, then we go through those basics again. So let's readdress the load management. So the first time the patient came in, we would have done a detailed patient interview trying to identify not just the common mechanisms that aggravate everyone's tendons, but for that person, what do they do in their everyday life? What do they do in their sport and recreation? And try to identify things that might be key drivers for their problem. So if they're having trouble, we go back and we readdress those things and go, right, well, what changes have you made? Can we make further changes to make that load management more successful? Then we go to the exercise program. Go, right, so have you been doing, your exercises regularly? How often have you been doing them? Mm-hmm. And if they say, maybe once every week or two, that's not going to be enough volume. So, and now
if they're being honest.
If they're being honest. But it's great that we have the LEAP trial evidence now that we can say, well, we know that you need to be having exercising regularly and you need to do enough volume of exercise to have an effect. And then the other thing is the intensity of exercise. So in the LEAP trial, we did make a particular effort on 3 days a week. They were working at a hard to very hard level. And we used an effort score, a modified Borg score. So they had to be working at a hard to very hard level at 3 times a week because we're trying to change the load capacity of those tendons. So we ask the patient, well, how hard are you working on those days? And particularly if they're doing primarily a home program, how hard are you working? Are you feeling fatigued? How would you rate your effort level on this scale? So if they're only working at a 2 or 3 level, that's not going to be hard enough. Mm-hmm. So we need to make sure that obviously monitoring how they respond with their pain. So we don't jump straight to a high load exercise. We graduate slowly towards it, monitoring their pain. But if they're not working at that 7 out of 10 level 3 times a week, we might not be working at an optimal intensity to get the change in load capacity that we need for those tendons. Mm-hmm. So I think those are probably the big things that we really need to address with patients.
Mm-hmm. Thank you. I have another, maybe a case study that I wanted to present to you. Earlier this week, I had a patient who, with a gluteal tendinopathy, she was progressing very well. She was doing the exercises. She had the proper education. But the thing she struggled with the most and still had symptoms with was during the night. That's something we haven't addressed yet. Can you give some good advice for patients about avoiding compression to the tendons? And maybe tell us something about the quarter to prone position that you mentioned during the course. Mm-hmm.
So nighttime is a particular problem for this population because if they're lying on their side, then the underneath side is being directly compressed, whereas even the top side, if the knee's hanging down into adduction, and particularly if they're in quite a lot of flexion, there's a lot of compression for that top side as well. So some people find that if they try to minimize the amount of time they spend on that sore side, that can help. Or in Australia anyway, there is available like a soft undulating foam that you can put over the mattress that can help soften the mattress a little bit. Some people find lying on their side just putting, a fattish pillow between their knees and their ankles. It has to be between knees and ankles.
Like with a pregnancy pillow?
Something like a pregnancy pillow, but it shouldn't just be a thin cushion between the knees. So it needs to be between knees and ankles. That can be quite useful. if they are able to comfortably sleep on their back, if they're in supine, then there's reduced compression as long as they're not crossing their ankles. Some people will find that they get lower back pain lying on their back though, but putting a pillow between the knees can help. But the most successful position that we have found is, we call it from quarter from prone, which is basically a position halfway between side lying and lying on your tummy. So if they lie on their affected side, often that's actually the most useful. So straighten that bottom leg, so the bottom affected leg is straight, and they roll their whole body and trunk halfway towards the bed, so that they are now not weight-bearing on their greater trochanter, they're weight-bearing on their anterolateral thigh. So for most people, that's quite comfortable. So then the top leg is, because they've rolled halfway towards the bed, the top hip is now no longer in adduction, it's actually in a position of abduction. But to keep them comfortable for the more prolonged periods that you spend when you're sleeping, we have a big pillow that we tuck underneath the hip and the tummy, so that they're resting on that top hip, and then they sometimes have another pillow in front to hug. But that's actually been the position that we've found most useful for patients.
I will try that with this particular female patient, and I'll let you know about the results.
Yeah, great.
I think it's time to wrap it up, because we have another appointment in the restaurant.
Yes, very
important. We're going to enjoy not only the outside and the city, but also the restaurant, the inside of the city. And let's enjoy some great food, some beer maybe afterwards. All the best of Belgium.
All the best of Belgium. Yeah, fantastic. Yeah. Looking forward to it.
Thank you for being with us today and last weekend. We hope to see you again maybe next year. And for all our listeners, thank you for joining us. Be sure to keep an eye on our website, to our program, and hopefully see you in the future. Thank you. See you soon.